Hello, everyone. My name is Dennis Calnon, and it is my pleasure to present the clinical value of cardiac PET. This presentation was created in conjunction with Drs. Daniel Junot, Dr. Linda Gearing, and Dr. Ian McGee. I have no financial disclosures. We're going to cover the strengths of cardiac PET imaging, focusing on the excellent diagnostic accuracy, consistently high image quality, the protocol efficiency, the low radiation exposure, peak stress imaging and left ventricular ejection fraction reserve, myocardial blood flow and myocardial blood flow reserve, coronary artery calcification assessment with PET-CT systems, and we'll talk about applications beyond myocardial perfusion imaging briefly as well. Let's start with the excellent diagnostic accuracy. This was a study that was done prospectively, comparing diagnostic accuracy of several different advanced imaging modalities compared to the reference standard of invasive coronary angiography with invasive FFR to measure functional significance. And in this study, on head-to-head comparison, the highest accuracy was achieved with PET with an accuracy of 85%, followed by SPECT at 77%, and CCTA at 74%. O15 water was used as the PET tracer in this study. It's easy to understand why the diagnostic accuracy is high when you start thinking about some of the characteristics of cardiac PET. First of all, attenuation correction is performed routinely and is very robust with PET. Similarly, scatter correction is performed routinely and is robust. Spatial resolution is very good for rubidium, as we'll see some examples of images, and is really excellent with N13 ammonia and F18 fluoropyridaz because of the excellent spatial resolution, because of the positron range being much shorter. Myocardial tracer uptake is good with rubidium and excellent with N13 ammonia and fluoropyridaz, and of course is nearly perfect with O15 water. Timing of stress imaging is also something that is important, and images are acquired at peak stress with rubidium and early post-stress with ammonia and with fluoropyridaz. Because of the robust attenuation correction, the robust scatter correction, and the high spatial resolution, it's easy to understand why cardiac PET has very high diagnostic specificity. Let's look at a couple of representative images. This is a normal rubidium myocardial perfusion imaging study shown in grayscale on the left and in a color scale on the right. These images were provided by Dr. Tim Bateman. You can see that the cavity of the left ventricle is very well resolved from the myocardium. The myocardial uptake is quite uniform and homogeneous. And even though there is some GI tracer activity present on this rubidium image, it's easy to separate the heart from the GI tracer activity and is not really problematic. So this is an example of a normal rubidium study. This is an example of a normal ammonia study. Here images were provided from Dr. Marcelo Di Carli. You can see that the image quality and the spatial resolution is even higher. The left ventricular cavity looks larger. The papillary muscles can sometimes even be resolved because of the excellent spatial resolution here on these ammonia images. Similarly, this is an example of a normal F18 fluoropyridaz study. These images were borrowed from Dr. Panithia Acharyan-Tatawi, and you can see again that the resolution is excellent, the image quality is excellent, and again, you can sort of resolve some of the papillary muscles because the spatial resolution is so good. These images will only get better and better as more of us transition to more advanced PET scanners with digital PET technology. The PET myocardial tracers also have excellent myocardial tracer kinetics, which is very important. As you might recall, all of the myocardial tracers in general underestimate the disparity in myocardial blood flow between normal and abnormal regions because tracer uptake is not linear at high myocardial blood flow rates. So for example, with our commonly used SPECT tracers, such as sestamib or tetraphosphamine, there's quite a bit of plateau and uptake, leading to an underestimation of the severity and extent of ischemia. Rubidium, being a potassium analog, it has an uptake more similar to thallium and is better. Ammonia has excellent myocardial tracer uptake. Flurpiridaz has perhaps even slightly better. And as I mentioned earlier, O15 water basically is freely diffusible and has essentially perfect myocardial uptake versus myocardial blood flow, and is excellent for quantifying myocardial blood flow. Because of the high myocardial tracer extraction, as well as the fact that we measure left ventricular function at peak stress, which we'll talk more about in a moment, and because of measuring absolute myocardial blood flow and myocardial blood flow reserve, it's also easy to understand why cardiac PET has high diagnostic sensitivity as well. So there's really no trade-off required. You can get high specificity and high sensitivity with the same test, which is a strength. The protocol efficiency is another strength of cardiac PET. This is the protocol that we use in my laboratory at Riverside Methodist Hospital in Columbus, Ohio. We start with a brief topogram image for positioning, followed by a CT attenuation map, which only takes about 4 seconds with our protocol. The 7-minute resting perfusion scan is acquired next, followed by pharmacologic stress. We are currently using regadenoson, and followed by a 7-minute peak stress acquisition that is also gated and allows for assessment of myocardial blood flow. This entire protocol only takes about 20 to 23 minutes on average, which is very time efficient. An ammonia study takes a little bit longer due to the slightly longer half-life, but ammonia studies can also be performed in a little more than 1 hour, depending on the protocol that's used. So this is very excellent, and another strength of cardiac PET imaging. The low radiation exposure is another major advantage. You might recall that ASNC produced a document several years ago stating that laboratories should strive to achieve average radiation exposures for their patients below 9 millisieverts. And that's a little bit more difficult to achieve with conventional SPECT imaging, with conventional cameras and conventional protocols. Obviously, dual isotope imaging, which is not used often, has quite a high radiation exposure associated with that protocol, whereas PET, based on this data from the IAC, has consistently low radiation exposure. The other important thing to remember is that because of the very short half-life of rubidium and the short half-life of ammonia, there is very low radiation exposure to hospital staff and family members following the test. Another major strength of cardiac PET is the ability to measure left ventricular ejection fraction and volumes during peak stress. Several groups, including the group from Brigham and Women's under the direction of Dr. Dorbala, have shown that if you look at the peak stress left ventricular ejection fraction during vasodilator stress compared to the resting left ventricular ejection fraction, you'll see that in normal patients, there's often an increase in left ventricular ejection fraction at peak stress compared to rest. That's called the left ventricular ejection fraction reserve. Whereas as the extent and severity of obstructive coronary artery disease increases, there'll be a blunting of the left ventricular ejection fraction reserve. And in patients with severe and extensive coronary artery disease, we will see a decline in left ventricular ejection fraction, as well as we'll often see an increase in left ventricular end-systolic volume at peak stress compared to rest. And this is a marker of high-risk coronary artery disease. The other thing that was shown in one of the studies from Dr. Dorbala's group was that if the left ventricular ejection fraction reserve is nice and normal, they defined as greater than or equal to increase of 5% during peak stress, this is associated with a 97% negative predictive value for excluding left main or 3-vessel coronary artery disease. So very helpful in providing reassurance. Myocardial blood flow and myocardial blood flow reserve are also extremely important. These are images taken from an excellent review from Dr. Viviani Tacchetti and Marcello Di Carli that point out the fact that coronary blood flow is not dependent only on the epicardial coronary arteries that are visible in the invasive coronary angiography, but also on the microcirculation as well. And this will be covered in another monograph, but I'll just briefly cover some of this as it really is one of the major strengths of cardiac PET. Myocardial blood flow reserve is defined as the peak stress myocardial blood flow divided by the resting myocardial blood flow. And the advantage of this measurement is that it provides an integration of the effect of focal epicardial coronary stenosis, diffuse epicardial atherosclerosis, and coronary microvascular disease. And by providing this information, it really provides excellent value, as we'll discuss. Myocardial blood flow reserve adds diagnostic value. For example, in this study from Dr. Naya and colleagues, they looked at patients who had normal perfusion images or mildly abnormal perfusion images, and then looked at the prognostic or the diagnostic value of incorporating myocardial blood flow reserve. And what they found, importantly, is that a normal myocardial blood flow reserve, here defined as greater than 1.93 as a cutoff, has a 97% negative predictive value for excluding high-risk coronary artery disease. So myocardial blood flow reserve adds significant diagnostic value. Similarly, myocardial blood flow reserve shows excellent prognostic value. This has been shown in multiple studies by multiple groups. Shown here is a recent large study of more than 12,000 patients published by Dr. Krishna Patel from the Kansas City group with Dr. Bateman, who showed that in the overall population, or in those with no ischemia based on relative perfusion imaging, or those with mild ischemia, defined here as 1 to 10% of the left ventricular myocardium, or greater than 10% with more severe or extensive ischemia, in all situations, the presence of myocardial blood flow reserve less than or equal to 1.8, which was the cutoff in this study, showed excellent prognostic value. In fact, the authors pointed out that for every 0.1 unit decrease in myocardial blood flow reserve, this was associated with a 9% greater hazard of death. So myocardial blood flow reserve has excellent prognostic value. And finally, myocardial blood flow reserve is able to help guide patient management. Dr. Patel, in this similar study, also was able to demonstrate that using the cutoff of 1.8, patients with myocardial blood flow reserve less than or equal to 1.8 had a survival benefit from early revascularization within 90 days of the PET study. So to summarize, myocardial blood flow reserve has diagnostic value, prognostic value, and is able to guide patient management as well. Let me just show an example to demonstrate what we can learn from myocardial blood flow reserve measurements. When myocardial blood flow reserve is normal, as it is here in this patient with completely normal myocardial blood flow reserve, what does this mean? This means a lot. This means that the patient does not have obstructive coronary artery disease, that the patient would not benefit from revascularization, that the patient does not have coronary microvascular disease, and very importantly, and often overlooked, this also confirms the fact that the patient did, in fact, respond to vasodilator stress, something that we are unable to determine based on just relative perfusion imaging alone without measuring myocardial blood flow and myocardial blood flow reserve. So I think as I think that you can see that myocardial blood flow reserve has excellent value clinically, and for this reason, it was appropriately highlighted in the 2021 chest pain guideline. There were several instances where it was pointed out as helpful in patients with obstructive disease who present with stable angina, as well as in patients with suspected INOCA. It was given a class 2A indication to add myocardial blood flow reserve if available. The next helpful piece of information is the ability to assess coronary artery calcification with PET-CT systems. Many of the modern PET systems that are on the market presently combine PET with CT for purposes of attenuation correction, and you can take advantage of the fact that the CT images are available for review, and you can identify the presence of calcification, as you can see in this patient, in the left main and the LAD and the circumflex, as well as the right coronary artery. And that adds extra information. So if you start thinking about all the information that you are achieving from a PET-CT study, you can get relative perfusion, relative to the most normal region, as we're all used to getting with SPECT imaging. You can measure resting and peak stress, left ventricular ejection fraction and wall motion. You can measure resting and peak stress myocardial blood flow and myocardial blood flow reserve, left ventricular ejection fraction reserve. You can verify the response to vasodilator stress, and you can assess coronary artery calcification as a manifestation of subclinical coronary artery atherosclerosis to identify patients who are likely to benefit from more aggressive preventive therapy. So lots and lots of information provided with modern cardiac PET imaging. Let's just talk briefly about some of the applications beyond myocardial perfusion imaging. One of these is, of course, the assessment of myocardial viability. For many years, cardiac PET imaging with FDG metabolism assessment has been considered really a gold standard for the assessment of myocardial viability. As you can see in this study, comparing multiple different imaging modalities for assessing myocardial viability, that the highest sensitivity test is really FDG PET. And it's really, FDG PET is the only modality capable of directly visualizing and identifying hibernating myocardium, which is a major advantage. Another major application for cardiac PET is the ability to assess cardiac sarcoidosis. And you can see here that there are multiple different combinations of perfusion patterns and FDG metabolism uptake to identify normal patients from those who are abnormal and have different stages of cardiac sarcoidosis involvement. And if you compare the ability of FDG PET versus CMR for assessing cardiac sarcoidosis, there are some similarities and some differences. Cardiac CMR obviously is excellent at identifying and quantifying fibrosis and scar, although this can also be done based on perfusion imaging, with resting perfusion imaging with FDG PET. Measurement of left ventricular ejection fraction and wall motion are quite good with both modalities. However, the differences start to occur when you think about the ability to distinguish scar from active inflammation, the ability to assess response to therapy, the feasibility of performing the test in patients with very severe renal failure, as well as the feasibility in all patients with cardiac implanted electronic devices. You can see that there are several advantages favoring FDG PET over CMR. And so the two modalities are both helpful and complementary, but in some cases, FDG PET can be very helpful. Finally, I just want to review some of the other exciting emerging clinical applications of cardiac PET. Coronary microvascular disease, we've already briefly touched on, is something that is already becoming widely used. And I believe that as specific treatments become available for treating patients with coronary microvascular disease, I think we're going to see a dramatic further increase in the use of cardiac PET imaging with myocardial blood flow assessment. Cardiac allograft vasculopathy is another condition that is ideally suited to cardiac PET with myocardial blood flow measurement due to the diffuse nature of the pathologic process, which makes it more difficult to assess with angiographic techniques or relative perfusion techniques. Prosthetic valve infection, LVAD infection, this is something that is already used very commonly with FDG PET imaging for assessing these infections. Vasculitis and myocarditis is also something that is being explored with cardiac PET. Cardiac amyloidosis, there are some tracers that are being evaluated that might be very useful clinically for evaluating patients with suspected cardiac amyloidosis. And myocardial blood flow reserve measurements are very severely reduced in patients with cardiac amyloidosis, which may provide prognostic value or the ability to assess response to therapy. Similarly, patients with aortic stenosis, myocardial blood flow reserve measurements can be helpful in identifying patients with moderate to severe aortic stenosis who are asymptomatic and identifying those who are at higher risk for adverse outcome and may benefit from earlier referral for TAVR or surgical aortic valve replacement. Hypertrophic cardiomyopathy patients also will demonstrate abnormalities with cardiac PET and myocardial blood flow measurements, and this may prove useful for prognostic assessment. And finally, heart failure with preserved ejection fraction patients will demonstrate abnormalities in myocardial blood flow. And there is certainly excitement about the ability to measure myocardial blood flow and blood flow reserve in this very large patient population to assess prognosis and response to therapies. So in summary, the strengths of cardiac PET imaging include the excellent diagnostic accuracy, the consistently high image quality, the protocol efficiency, the low radiation exposure, the ability to measure peak stress imaging and to measure left ventricular ejection fraction reserve, the ability to measure myocardial blood flow and myocardial blood flow reserve, coronary artery calcification assessment if you use PET-CT systems, and finally, many exciting applications beyond myocardial perfusion imaging. So with that, I want to thank you very much for listening.